I need to tell you something that's going to make you uncomfortable. Something that might challenge everything you thought you knew about the medications you write prescriptions for every single day. I'm speaking to you as a colleague, as someone who stood exactly where you're standing right now, prescription pad in hand, trying to do right by your patients. But here's the truth nobody talks about in grand rounds or continuing education seminars. 5 medications that we prescribe routinely, medications that seem completely benign, are silently destroying the cardiovascular systems of our older patients. And the worst part? Most of us have no idea it's happening until it's too late. Let me be direct. This isn't about rare adverse events buried in package inserts that nobody reads. This isn't about theoretical risks that show up in animal studies, but never materialize in clinical practice. I'm talking about real patients, real damage, real consequences that I've witnessed firsthand over 2 decades of practice. The kind of damage that shows up in your emergency department at 3 in the morning. The kind that turns a routine follow-up into a code blue. The kind that makes families ask you with tears in their eyes, how could this happen when we were doing everything right? The pharmaceutical industry has done an exceptional job convincing us that these medications are safe. The FDA has approved them. The guidelines recommend them. Our colleagues prescribe them without hesitation. But when you actually look at the data, when you follow the patients long-term, when you see the patterns emerging across thousands of cases, the picture becomes crystal clear. We're inadvertently harming the very people we're trying to help, and it's happening on a massive scale. Before I reveal these 5 medication classes, I want you to think about your patient panel. Think about your 70-year-old with chronic pain who comes in every 3 months. Think about your 65-year-old with reflux who's been on the same medication for years. Think about the 82-year-old who catches every cold and always asks for something to help her breathe. Now multiply that across your entire practice, across your hospital, across the entire healthcare system. That's the magnitude of what we're dealing with. What I'm about to share goes against conventional wisdom. Some of your colleagues might dismiss it. Some might even get defensive because nobody wants to believe they've been harming patients. But I'm asking you to set aside your assumptions and look at this with fresh eyes. Look at it through the lens of evidence-based medicine. Look at it through the lens of first do no harm. Because by the end of this discussion, you'll understand exactly which 5 medication classes are causing silent cardiovascular damage in our elderly patients, why the risk increases so dramatically after age 60, and most importantly, what you can do starting tomorrow morning to protect your patients from this preventable harm. This is about being better clinicians. This is about staying ahead of the curve instead of learning about complications from morbidity and mortality conferences. This is about having the courage to question standard practice when the evidence demands it. So let's begin with number 5, a medication class that's in virtually every patient's medication reconciliation list. The one that seems so harmless that we barely think twice about it anymore. Number 5, nonsteroidal anti-inflammatory drugs. I can already hear some of you thinking, we already know about NSAID risks. We warn patients about GI bleeding. We're careful with renal function. But what I'm talking about goes deeper than the warnings you were taught in medical school. I'm talking about the insidious cardiovascular toxicity that we routinely underestimate, especially in the over 60 population. Let me tell you about a case that changed how I prescribe forever. Robert was 73, came to see me for management of his osteoarthritis. No significant cardiac history, blood pressure well controlled on a single agent, lipids optimized, active lifestyle, walked 3 miles daily. His primary care physician had him on ibuprofen 800 milligrams 3 times daily for the past 18 months. Standard dose, right? Nothing excessive. Robert did great initially. Pain improved, function improved, quality of life improved. Then one afternoon, he came back looking completely different. Profound fatigue, dyspnea on minimal exertion, bilateral lower extremity edema that had appeared seemingly overnight. We admitted him. Brain natriuretic peptide was through the roof. Echocardiogram showed an ejection fraction that had dropped from 55% 18 months ago to 30% now. Acute decompensated heart failure in a man who had 0 cardiac symptoms before starting that NSAID. We stopped the ibuprofen. We diuresed him aggressively. We optimized his heart failure medications. He eventually stabilized, but his ejection fraction never fully recovered. That one seemingly innocent prescription for arthritis pain had permanently damaged his heart. Here's what makes NSAIDs so dangerous in the elderly population. They don't just block cyclooxygenase to reduce inflammation. They fundamentally alter the delicate balance of prostaglandins that regulate renal function and vascular tone. In a young, healthy person with robust compensatory mechanisms, the body can handle this. But in a 70-year-old with age-related arterial stiffness, with kidneys that have lost 30% of their function just from normal aging, with a renin-angiotensin system that's already working overtime to maintain blood pressure, NSAIDs become a catastrophic insult. The mechanism is actually quite elegant in its destructiveness. NSAIDs cause sodium and water retention by interfering with renal prostaglandin synthesis. This increases intravascular volume. Simultaneously, they cause vasoconstriction, increasing afterload. So now the heart is pumping against increased resistance while dealing with increased volume. For an aging heart with reduced compliance and impaired diastolic function, this is the perfect storm. The heart simply cannot keep up. Acute heart failure develops, and it develops quickly. The data backs this up completely. A meta-analysis of over 600,000 patients showed that all NSAIDs increase the risk of heart failure hospitalization, not by a trivial amount. We're talking about a 19% increased risk with naproxen, which we used to think was the safer option, 24% with ibuprofen, 58% with diclofenac, and these aren't rare events. Heart failure is already the #1 cause of hospitalization in patients over 65. We're making an epidemic worse every time we write these prescriptions without thinking carefully about cardiovascular risk. But here's what really concerns me as a clinician. We know all this. The FDA mandated black box warnings about cardiovascular and gastrointestinal risks back in 2005. Every major cardiology society has published statements about NSAID risks, yet we continue prescribing them like candy. Why? Because the patient is in pain. Because they're asking for relief. Because we feel like we need to do something. And in that moment, with a packed waiting room and 15 minutes per patient, it's easier to write the prescription than to have the difficult conversation about non-pharmacologic alternatives. The evidence tells us that the risk is dose-dependent and duration-dependent. Low-dose naproxen for 3 days is vastly different from high-dose ibuprofen for 3 months. But how many of our patients actually follow that guidance? We write for 30 days with 3 refills. The patient feels better, so they keep taking it. 6 months later, they're still on it. A year later, they're in heart failure and nobody connects the dots back to that initial prescription for knee pain. And if your patient is already on low-dose aspirin for cardiovascular protection, there's another layer of danger you need to know about. Ibuprofen competitively inhibits the antiplatelet effect of aspirin. So not only are you increasing heart failure risk, you're simultaneously removing the cardioprotective benefit of the aspirin. It's a double hit. The timing matters too. If they take ibuprofen before aspirin, the inhibition is almost complete. Most patients have no idea about this interaction. Most prescribers don't counsel on it. And the pharmacy software might flag it, but how many patients actually read those warnings? The solution isn't to never prescribe NSAIDs. That's unrealistic. Pain is real. Inflammation is real. Quality of life matters. But the solution is to prescribe them intelligently. Lowest effective dose, shortest duration possible. Consider topical formulations that have minimal systemic absorption. Consider acetaminophen, which despite its own risks doesn't carry the same cardiovascular toxicity. And most importantly, have an honest risk-benefit conversation with every patient over 60 before writing that prescription. Document that conversation, make it part of your standard practice. Now let's move to number 4, and this one is going to surprise you because it's a medication class we prescribe specifically to protect patients from harm. I'm talking about proton pump inhibitors. Omeprazole, pantoprazole, lansoprazole, esomeprazole, the medications we give to prevent NSAID-induced ulcers, the medications we prescribe for reflux and think nothing of continuing indefinitely, the medications that are among the most commonly prescribed drugs in the entire world. I want you to think about how many of your patients are on a PPI right now. Not for a specific indication with a defined endpoint, but just on it. Maybe it was started years ago by a different provider. Maybe the patient had some mild reflux symptoms and it helped, so they never stopped. Maybe it was started in the hospital for stress ulcer prophylaxis and somehow made it onto the discharge medication list, and nobody ever questioned it. This happens constantly. PPIs have become the pharmaceutical equivalent of background noise. They're so ubiquitous that we've stopped thinking critically about them. Let me tell you about Margaret. 68 years old, came to my clinic for management of hypertension. Medication reconciliation showed she'd been on omeprazole 40 milligrams daily for 7 years. 7 years. I asked her why she was taking it. She said her previous doctor prescribed it for heartburn. Did she still have heartburn? No, she hadn't had symptoms in years, but nobody had ever told her to stop, so she just kept taking it. This story is not unique. This is the majority of patients on chronic PPI therapy. Here's where it gets concerning from a cardiovascular standpoint. We've known for years about PPI-associated nutrient malabsorption, magnesium in particular. The FDA issued a warning in 2011 about hypomagnesemia with prolonged PPI use. But have you actually checked magnesium levels on your patients who've been on PPIs for years? Most of us haven't. And magnesium deficiency isn't some abstract laboratory abnormality. It has real clinical consequences for cardiac function. Magnesium is essential for maintaining normal cardiac rhythm. It's a natural calcium channel blocker. It stabilizes cardiac myocyte membranes. When magnesium levels drop, you see increased automaticity, increased triggered activity, and increased risk of both atrial and ventricular arrhythmias. We're talking about atrial fibrillation, ventricular ectopy, torsade de pointes in severe cases. I've seen patients develop new onset atrial fibrillation after years of PPI use, and when we checked their magnesium, it was critically low. We supplemented aggressively, and in some cases, the arrhythmia resolved. The PPI was the culprit all along. But the magnesium story is just the beginning. There's mounting evidence linking PPI use to increased cardiovascular events, and the mechanism isn't entirely clear yet, which makes it even more concerning. Multiple large observational studies have shown associations between PPI use and increased risk of myocardial infarction. One study of nearly 3 million patients found a 16 to 21% increased risk of MI in PPI users compared to non-users. Another study showed increased cardiovascular mortality. These aren't small, underpowered studies. These are massive data sets showing consistent signals. The proposed mechanism involves nitric oxide. PPIs may inhibit dimethylarginine dimethylaminohydrolase, an enzyme that degrades asymmetric dimethylarginine, which is an endogenous inhibitor of nitric oxide synthase. Follow that chain, and you end up with reduced nitric oxide bioavailability. Less nitric oxide means impaired endothelial function, increased vasoconstriction, accelerated atherosclerosis. It's biologically plausible, and the observational data supports it. But we don't have the randomized controlled trial yet that definitively proves causation. Some of you are thinking observational studies have limitations, confounding by indication, residual confounding, and you're absolutely right. But here's my question. Given that we know PPIs are overprescribed, given that we know many patients are on them without a clear indication, given that we know about the magnesium issue and the potential cardiovascular signals, why are we waiting for perfect evidence before we act? Why aren't we deprescribing inappropriately used PPIs right now? There's another interaction that's absolutely critical and frequently missed. Clopidogrel. If you have a patient on clopidogrel after an acute coronary syndrome or after stent placement, and you co-prescribe a PPI, particularly omeprazole or esomeprazole, you're potentially reducing the antiplatelet effect of the clopidogrel. Clopidogrel is a prodrug. It requires CYP2C19 for activation. Omeprazole is a strong CYP2C19 inhibitor. The interaction is real, documented, and clinically significant, yet I still see this combination prescribed all the time. The cardiology societies recognize this. The guidelines say if a patient absolutely needs both clopidogrel and a PPI, use pantoprazole instead because it has less CYP2C19 inhibition. But how many primary care offices have that level of detail in their prescribing protocols? How many patients are walking around with suboptimal platelet inhibition because nobody caught this interaction? These are the patients who come back with stent thrombosis 6 months later, and we wonder what went wrong. The message here isn't that PPIs are inherently dangerous or should never be used. They're incredibly effective for their intended indications: active peptic ulcer disease, erosive esophagitis, Zollinger-Ellison syndrome, pathologic hypersecretory conditions. Use them when indicated, use them at the appropriate dose, and most importantly, use them for the appropriate duration. The problem is that we've normalized chronic indefinite use for conditions that could often be managed with lifestyle modification or intermittent therapy. If you have a patient on long-term PPI therapy, ask yourself these questions. What was the original indication? Is that indication still present? Have we tried stepping down the dose or stopping it entirely? If they truly need chronic acid suppression, have we checked their magnesium level? Are they on any medications that interact? This should be part of your routine medication review, especially in patients over 60 where polypharmacy is already a concern. Now we arrive at number 3, and this one is particularly insidious because patients don't even think of it as a medication. I'm talking about over-the-counter oral decongestants, pseudoephedrine and phenylephrine, the active ingredients in virtually every cold and flu remedy on pharmacy shelves, the medications that patients buy without a second thought because they're not prescription drugs, so they must be safe. The medications that can trigger acute hypertensive crisis and cardiac arrhythmias in our elderly patients. Here's a scenario that plays out in emergency departments across the country every single winter. A 75-year-old patient with well-controlled hypertension catches a cold, feels miserable, goes to the pharmacy, picks up a multi-symptom cold remedy, takes it as directed on the package. Within 24 to 48 hours, they're in the emergency department with blood pressure of 200/120, palpitations, chest discomfort, severe headache. The ER team scrambles. Is this a hypertensive emergency? Are we looking at acute coronary syndrome? Extensive workup. IV antihypertensives. Cardiac enzymes. Electrocardiogram. The whole 9 yards. And then someone takes a careful medication history. They find out about the cold medicine. They stop it. Within 12 to 24 hours, the blood pressure normalizes. The palpitations resolve. It was entirely iatrogenic, entirely preventable. And it happens over and over again because these medications are available without a prescription, and patients assume they're benign. The mechanism is straightforward but powerful. Pseudoephedrine and phenylephrine are sympathomimetic amines. They're alpha-adrenergic agonists. Their therapeutic effect, decongestion, comes from vasoconstriction of the nasal mucosa, but they don't act only locally. Once absorbed systemically, they cause vasoconstriction throughout the entire vascular system. This increases systemic vascular resistance dramatically. The heart has to pump against much higher afterload. Blood pressure spikes. And in a patient whose cardiovascular system is already compromised by age, by hypertension, by coronary disease, this can be catastrophic. Beyond the hypertensive effect, these agents also have direct cardiac stimulant properties. They increase heart rate. They increase myocardial oxygen demand. They can provoke arrhythmias, particularly in patients with underlying conduction system disease or in patients on other medications that affect cardiac electrophysiology. We're talking about atrial fibrillation, supraventricular tachycardia, ventricular ectopy. I've personally seen patients develop rapid atrial fibrillation triggered solely by pseudoephedrine use. The European Medicines Agency has been scrutinizing pseudoephedrine closely due to reports of posterior reversible encephalopathy syndrome and reversible cerebral vasoconstriction syndrome. These are rare but devastating neurological complications caused by the severe vasoconstrictive effects. If it can constrict cerebral vessels to that degree, imagine what it's doing to coronary vessels in a patient with underlying atherosclerosis. Here's what makes this particularly challenging. These medications are effective. They work. Patients feel better. Their nasal congestion resolves. So they keep using them. And because they're over-the-counter, there's no healthcare provider in the loop to counsel them on risks or monitor for adverse effects. The package insert has warnings, sure, tiny print that nobody reads. Warnings that say don't use if you have high blood pressure or heart disease. But does a 70-year-old with a stuffed nose read the fine print? Or do they just take what worked for them 30 years ago when they were younger and healthier? This is where we as clinicians need to be proactive. Every patient over 60, especially those with hypertension or any cardiovascular disease, needs explicit counseling about over-the-counter medications. Not just a generic warning. Specific guidance. Write it in their after-visit summary. Tell them explicitly. No pseudoephedrine, no phenylephrine. Give them alternatives. Saline nasal spray. Nasal corticosteroids that act locally without systemic absorption. Humidification. Steam inhalation. These approaches are safer and often just as effective. And we need to be asking about this in our medication reconciliations. Don't just ask about prescription medications. Ask specifically about over-the-counter products. Ask about cold medicines, allergy medications, sleep aids, pain relievers. Ask about supplements. Because your patients don't think of these as medications, they won't volunteer the information unless you specifically probe for it. and these are often the agents causing the unexplained blood pressure elevation or the new arrhythmia that nobody can figure out. Moving to number 2, and this is a delicate topic because we're talking about medications that treat serious psychiatric conditions. I'm referring to tricyclic antidepressants. Amitriptyline, nortriptyline, imipramine, doxepin. These are older antidepressants that we don't use as first line for depression anymore, but they're still prescribed frequently for neuropathic pain, for migraine prophylaxis, for insomnia. And in elderly patients, they carry significant cardiovascular risk that's often underappreciated. The challenge here is that depression itself is a cardiovascular risk factor. Untreated depression increases risk of myocardial infarction, worsens outcomes after cardiac events, and increases mortality. So treating depression is important. Treating chronic pain is important. Quality of life matters. But how we treat it matters enormously, particularly in the elderly population, where the therapeutic window is narrower and the consequences of adverse effects are more severe. Tricyclic antidepressants have multiple mechanisms of action that affect the cardiovascular system. They have anticholinergic properties. They block alpha-adrenergic receptors. They have quinidine-like membrane-stabilizing effects on cardiac tissue. Each of these mechanisms can cause problems, and when you combine them in an elderly patient with age-related physiologic changes, you create a perfect storm for cardiovascular complications. The most common and most clinically significant effect is orthostatic hypotension. The alpha-adrenergic blockade impairs the normal compensatory vasoconstriction that occurs when you stand up. In a young, healthy person, this might cause mild dizziness. In a 78-year-old with impaired baroreceptor sensitivity and decreased intravascular volume, this causes syncope. And syncope in the elderly isn't just an inconvenience, it's a hip fracture. It's a subdural hematoma. It's a traumatic death. I had a patient, David, 81 years old, with painful diabetic neuropathy. Previous trials of gabapentin and pregabalin hadn't provided adequate relief. His pain specialist started him on low-dose amitriptyline, 25 milligrams at bedtime. The pain improved significantly. Quality of life improved. But 3 weeks later, he stood up from his recliner to answer the phone, became profoundly dizzy, fell and fractured his femur, required surgical repair, prolonged hospitalization, developed delirium, never returned to his baseline functional status. One medication, prescribed for a legitimate indication at an appropriate dose, changed the entire trajectory of his life. Beyond orthostatic hypotension, tricyclics have direct effects on cardiac conduction. They slow intraventricular conduction, which manifests as QRS widening on electrocardiogram. In therapeutic doses, this is usually mild. But in elderly patients with pre-existing conduction system disease, with bundle branch blocks or first-degree AV block, this additional slowing can be clinically significant. We're talking about complete heart block, ventricular arrhythmias, sudden cardiac death. The quinidine-like effects also prolong the QT interval, increasing risk of torsades de pointe, particularly if the patient is on other QT prolonging medications or has electrolyte abnormalities. Tricyclics also increase resting heart rate through their anticholinergic effects. This increases myocardial oxygen demand. In a patient with coronary artery disease, this can precipitate ischemia. And because these medications also have some pro-arrhythmic properties, you're creating a situation where demand is increased while simultaneously increasing the risk of dangerous rhythms. The evidence is clear that tricyclic antidepressants are no longer first line for depression in elderly patients. We have safer alternatives: selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, mirtazapine. These newer agents have much better cardiovascular safety profiles, but tricyclics are still used for neuropathic pain and other indications. If you're going to prescribe them in elderly patients, you need to do it thoughtfully. Start with the lowest possible dose. Monitor blood pressure closely, both seated and standing. Get a baseline electrocardiogram and follow up periodically. Watch for drug interactions. And always consider whether there's a safer alternative. Now we arrive at number 1, and this is going to be the most controversial point I make today. I'm talking about calcium supplementation. Yes, the pills that millions of people take daily for bone health. The supplements that seem so obviously beneficial that questioning them feels almost heretical. But the evidence is forcing us to question, and we need to pay attention. For decades, the message was unambiguous. Calcium is good for bones. More calcium is better. Take supplements if you're not getting enough from diet. We recommended it routinely, especially to postmenopausal women at risk for osteoporosis. It seemed like a no-brainer. But then the data started coming in, and it wasn't the data we expected. Multiple large observational studies have found associations between calcium supplementation and increased cardiovascular events. A meta-analysis of 11 randomized controlled trials involving nearly 12,000 participants showed that calcium supplementation increased the risk of myocardial infarction by 31%. Another meta-analysis showed increased risk of cardiovascular mortality. These aren't fringe studies. These are peer-reviewed publications in major journals analyzing thousands of patients. The hypothesis is elegant and concerning. When you consume calcium through food, it's absorbed gradually throughout the day. Your body regulates absorption based on need. Excess isn't absorbed. But when you take a supplement, particularly a high-dose supplement of 500 to 1,000 milligrams at once, you create an acute spike in serum calcium. Your body can't utilize all that calcium for bone mineralization immediately. The excess has to go somewhere. And the concern is that it deposits in arterial walls, contributing to vascular calcification and atherosclerotic plaque formation. We know vascular calcification is a major contributor to cardiovascular disease. Calcified arteries are stiff arteries. They can't dilate appropriately. They increase afterload on the heart. They're more prone to rupture. And calcified plaques are unstable plaques, the kind that cause acute coronary syndromes. So if calcium supplements are accelerating this process, we have a serious problem. The controversy exists because not all studies show this association. Some large trials found no increased cardiovascular risk. The evidence isn't definitive. But here's my position as a clinician. The risk-benefit ratio for calcium supplementation has shifted. For a patient with documented severe osteoporosis at high fracture risk, the bone benefits might outweigh potential cardiovascular risks. But for the average person taking calcium just because they think they should, the calculus is different. Dietary calcium doesn't appear to carry the same risk. Dairy products, leafy greens, fortified foods provide calcium in a form that's absorbed physiologically. So the recommendation should be food first. If supplementation is truly necessary, it should be a medical decision, not something patients self-prescribe. And if we do prescribe it, we should be monitoring for cardiovascular risk factors, ensuring vitamin D levels are adequate because vitamin D affects calcium metabolism, and considering lower doses spread throughout the day rather than large bolus doses. Let me synthesize what we've covered. 5 medication classes. NSAIDs causing heart failure through volume overload and increased afterload. PPIs depleting magnesium and potentially affecting endothelial function. Oral decongestants causing hypertensive crises and arrhythmias. Tricyclic antidepressants causing orthostatic hypotension and conduction abnormalities. Calcium supplements potentially accelerating vascular calcification. These aren't rare medications. These aren't exotic drugs used only in specialty practices. These are medications we encounter daily. And in patients over 60, the risks are amplified by age-related physiologic changes that reduce reserve and impair compensatory mechanisms. My goal today isn't to make you afraid of prescribing, it's to make you think critically about every prescription. To ask yourself, does this patient really need this medication? Is there a safer alternative? What's the lowest effective dose? What's the shortest appropriate duration? Are we monitoring appropriately for adverse effects? These questions should be reflexive, particularly in elderly patients where polypharmacy is already a major concern. The practice of medicine is about balancing benefits and risks. Every medication we prescribe has both. Our job is to maximize benefit while minimizing harm. And that requires staying current with emerging evidence, even when that evidence challenges our established practices. It requires honest conversations with patients about risks, not just benefits. It requires systematic medication reviews, looking for opportunities to deprescribe when medications are no longer indicated or when risks outweigh benefits. I'm asking you to take this information back to your practice. Look at your patient panel through this new lens. Identify the patients on chronic NSAIDs without clear ongoing indication. Find the patients on PPIs for years without documented need. Counsel your elderly patients about over-the-counter decongestants before cold season hits. Review Tricyclic prescriptions and consider safer alternatives. Have thoughtful conversations about calcium supplementation. These are concrete actions you can take starting tomorrow that will directly improve patient outcomes. Share this information with your colleagues. Discuss it in your practice meetings. Challenge each other to prescribe more thoughtfully. Because the patients sitting in our waiting rooms trust us completely. They assume that every medication we prescribe is necessary and safe. And while we can't eliminate all risk, we can certainly minimize preventable harm. That's our obligation. That's what separates good clinicians from great ones. The willingness to question, to learn, to adapt, and to always put patient safety first.